Because of the time constraints, I will not be going into the absolute details of, the explanations and all. We'll just discuss about the salient features only. So you can type your answers or you can unmute yourself and you can answer. So coming to the first question, a term infant born to a primigravida mother with antenatal polyhydramnios is noted to be apneic at birth. Despite corrective measures with positive pressure ventilation, baby remains blue. You intubate the baby. When after that there is improvement. You find the heart sounds are shifted towards the right side, then the right sternal border, and the baby has a scaphoid abdomen. So you decide to transfer the baby to an ICU with ongoing ventilatory support. So I will not be asking you about the diagnosis of this case because it is pretty straightforward. This is a case of congenital diaphragmatic hernia. So in the question, the pointers towards CDH is a polyhydramnios, worsening on positive pressure ventilation, shifting of the mediastinum with a scaphoid abdomen. Although the scaphoid abdomen in general practice is not that common occurrence, but yeah, literature may it's written that scaphoid abdomen is found. So the first question is, what is the embryological basis for this condition? You can type it on the chat box, or you can unmute yourself and say tell the answer. Very good. So it is due to the failure of the closure of the pleuroperitoneal pores, which usually occurs at 6 to 8 weeks of gestation. So as a result of which there is herniation of the intestinal contents into the hemithorax and there is arrest of the pulmonary alveolar as well as vasculature development. So now you know that the baby with the congenital diaphragmatic hernia, sorry, just a second, is about to be delivered. In the antenatal history, what are the prenatal predictors that you would look for poor outcome in this baby? Somebody has said lung head ratio. Okay, what else? Yes, Dr. Pooja. Okay. Observed to expected LHR. Anything else? So, okay, LHR less than 1, liver herniation, observed to expected LHR. What is observed to expected LHR? See, the LHR is the lung to head ratio. It is the lung area which is measured at the cardiac atria and the contralateral lungs. And when you divide this with the BPD, then you get the lung to head ratio. So because the lung to head ratio, it increases with increasing gestation age. There are normograms for the same. So if you divide the observed to expected lung to head ratio, it gives you an idea about the degree of pulmonary hypoplasia. Degree of pulmonary hypoplasia in the right side if it is less than 25%, and in the left side if it is less than 25%, and in the right side if it is less than 45%, it is an indicator of severe pulmonary hypoplasia. So are there any, these are all ultrasound markers, are there any MRI markers, fetal MRI markers? Yes, you do the LHR within 22 to 27 weeks of gestation. Are there any MRI markers? So in the MRI markers, you look for the total fetal lung volume. If it is less than 35%, it means there is severe pulmonary hypoplasia. So now you would want to, the definitive management of a CDH is surgery, right? So how do you assess the feasibility of this baby for surgery? Any parameters that you would like to check? Very good. Urine output more than 1 ml per kg per hour, lactate less than 3 millimoles per liter, preductal saturation between 85 to 95%, FiO2 requirement less than 50%, and subsystemic pulmonary. Very nice. Okay, shall we move to the next question? So here we have the second question. It is a G2P1 mother with a blood group O negative. He was taken up for emergency LSCS. There were signs of hydrops at 30 weeks of gestation. Antigen steroids were given and it received an in utero transfusion. At 35 weeks of gestation, there were evidence of increased MCA blood flow and early signs of hydrops. So, what are the signs of hydrops that are mentioned in the question above? Or, in other words, How do you define hydrops vitalis? Okay, ascites. What else? Pleural effusion. Okay, very nice. More than a collection of extracellular fluid in more than two body compartments. It might be the pleural space, it might be the pericardial space, it may be the peritoneal space, or also the skin diameter of more or the thickness more than 5 millimeter. And which other body compartments? The amniotic fluid is also considered to be a compartment, as well as placentomegaly as well. If there is placentomegaly and polyhydramnios, these two are also considered to be criteria. So, okay. Now you are a neonatologist and you know a baby with hydrops is going to be delivered. So how would you prepare yourself for receiving the baby? Okay. This is a hydrops baby, mind it. Okay. Somebody saying exit procedure, somebody saying ICD. Okay. So this is a high management of or detailed resuscitation of the newborns. The two trained personnel should be present. As well as because in this condition, because it is a hydros baby, you might need to, perform cardiosynthesis or a should be available in the delivery room. Plus, yeah, like somebody rightly said, you also have to send a cord blood for blood grouping, for DCT, for cord bilirubin, as well as hemoglobin. So if the hemoglobin is less than 10 gram per DL and the bilirubin is more than 5 milligram per DL, this would indicate that the baby would require exchange transfusion. So, okay, coming to the third question. What is the threshold for escalation of care as per the AAP guidelines for the management of these cases? Management of neonatal hyperbilirubinemia. Okay. Immediate action within 2 milligram of exchange transfusion, TSV value 2 below exchange transfusion level, IV fluids. Okay. What else? IVIG as a part of escalation of care? I don't think so, Dr. Pooja. Limit for the when do you escalate care in these cases? It is like you rightly said, when the bilirubin level is 2 less than the exchange transfusion criteria. So in those cases, you have to send the samples for cross matching. You have to send the samples for you know um, blood grouping, cross matching bilirubin levels, and the bilirubin levels you'll have to continue monitoring every 2 hourly till it is below the escalation of care threshold, as well as you have to continue intensive phototherapy in these cases. Okay, these are the components of escalated care. So at any point when the bilirubin it increases or reaches the exchange threshold, or there is signs of acute bilirubin encephalopathy, you are supposed to undergo, start double exchange transfusion. What is the role of IVIG in this situation? What dosage? The exchange transfusion level. But the thing is, some of the in the Cochrane and some Cochrane analysis, it has been shown that it really does not decrease the need for exchange transfusion in these babies, but they have advised that you can uh, give IVIG in these babies if there is if your center does not have the facility for exchange transfusion and prior to transfer. But American Academy of Pediatrics guidelines 2022, it does say that you can give IVIG in these patients just prior. 900 grams admitted in an ICU. The RBSK guidelines for screening these babies? Which babies are you supposed to screen? Okay. Okay. At what gestation age? Very with receptors. Okay, very nice. Okay. 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 So, in this baby, when would you like to do the ROP screening? Okay, why? What does the RBSK guideline say? 2 to 3 weeks. So the RBSK guideline says at 4 weeks, but in those babies who are less than 28 weeks or a weight of less than 1200 grams, screen for ROP at 2 to 3 weeks, because in the extreme preterm babies, these babies are prone to develop aggressive ROP. We no longer say aggressive posterior ROP because these babies have the propensity to give any pain relief. Okay, tropicamide eye drops. What else along with? Okay, you have to keep the baby NBM half an hour prior to the procedure and half an hour after the procedure. Dilate the eye with phenylephrine 2.5, yes, and tropicamide eye drops 0.4%, and you dilute it with carboxymethyl cellulose 1:1. You make, actually it is available at a concentration of 5% phenylephrine and 0.8% tropicamide. When you dilute it with carboxymethyl cellulose, it becomes the concentration becomes 2.5% phenylephrine and 0.4% tropicamide. So you instill it every 10 to 15 minutes, 3 to 4 times, 1 hour prior to the procedure. For pain relief, you can give express breast milk. You can swaddle the baby and at the same time keep a resuscitation kit ready, because preterm babies, when you do a eye examination, it can stimulate the vagal reflex and the baby might have apneas. So will you be able to mention a few risk models for the prediction of ROP based on postnatal weight gain? Very nice. Winrop algorithm. Gestation age, birth weight, IV. Okay. So you're talking about GROP. Okay. What else? WinROP. Just okay. So basically, the idea is decrease in insulin-like growth factors level 1 is a risk factor for the development of retinopathy of prematurity, right? So postnatal weight gain is a surrogate for the low, the poor postnatal weight gain is a surrogate for low insulin growth factor level. So this has been used as a parameter for screening babies who might or might not require ROP screening. So GROP, WinROP, then CHOP ROP, ROP score. These are the prediction models which uses gestation age, birth weight, as well as the postnatal weight gain. And GROP also uses the presence of IVH to decide whether this, it is a very cost-effective measure. So almost there was seen in the GROP algorithm, it was seen that in the study, it was seen that there was almost 30% reduction in the need for ROP screening. So, okay, let's move on to the next question. What are the indications for magnesium sulfate during pregnancy? A very easy question. How preterm? Neuroprotection, okay. Eclampsia, okay. Preterm baby is less than 32 weeks. And for neuroprotection, what is the mechanism and the dose for of magnesium for neuroprotection? The dose for neuroprotection was already mentioned in the preceding presentations. Less than 32 weeks, okay. 4 gram IV loading dose followed by 1 gram per hour till, very nice. What is the mechanism? Excitatory because it, okay, very nice. Exaggerated tendon reflex in the newborn. Increase cerebral blood flow. Okay, let's discuss about the mechanism of action. So it is anti-excitatory. So because it blocks the NMDA receptors. It is antioxidant because it facilitates the formation of glutathione. It is also a very good vasodilator. Also at the same time, it is antiplatelet and anti-cytokine also. All this help in the neuroprotection of the preterm babies less than 32 weeks. Yes, blockage of NMDA receptors. What are the side effects of magnesium injection in the newborn? Okay, okay. Anything else? Sorry, let me reshare. Oh, sorry, there was some technical snag. Am I audible and visible?
Yeah, now you are.
Yeah, okay. Were you able to hear what I spoke of in the question 4?
Yeah, I think the last part we couldn't.
Okay. So the side effects of magnesium injection in the newborn, hypotonia, lethargy, respiratory depression, and in some cases, feed intolerance also. Okay. Fifth question, extreme preterm newborn with a birth weight of 750 grams and gestation age of 26 weeks at 3 weeks of age is being treated for PDA, NAC stage 2 and hypoglycemia. So the baby is on CPAP and has received TPN and blood products in the recent past. On examination, the newborn baby this baby has pallor and jaundice. So when you look at the entire history, now that the baby has jaundice, what do you think are the possible causes at this stage? Okay, blood transfusion, sepsis. Sepsis, okay. Very nice. Cholestasis because the baby has received prolonged TPN. What else? What can blood transfusion cause? In NEC stage 2 leading to intestinal failure? CMV infection, very nice. What else? IVH can also cause pallor and jaundice, right? So Now, name 4 tests in order of priority you would like to do in this case. You know the causes. Now, how would you investigate this case? Okay. LFT, very nice. USG abdomen, very nice. Okay. Okay. So, wouldn't you send a sepsis screen because your first differential diagnosis was sepsis? Okay. You will look for same way hepatitis. You would be sending a sepsis screen. You would be sending a blood culture. You will do a urinary analysis and urine culture. You would send a TPN workup, LFT, a complete lipid profile. Look for CMV, IgM. You'll do a neurosonogram and ultrasound because the baby probably had central lines for a long time, or was probably. Let's move on to the next question. So this is a test that we commonly do. So what does this image show? Which test is being done here? Bera. Okay. So what are the anatomical correlates of the different weights seen in this test? So you have 7 waves, right? Wave 1, 2, 3, 4, 5, 6, and 7. So what does E. coli stand for? 7 waves. So 1 is eighth nerve. 2 is cochlear nucleus. Okay, very nice. 3 is superior olivary nucleus. Okay. 4 is 5 is inferior colliculus. 6 is thalamus. And 7 is thalamic radiation. So basically, the origin of wave 7 and 6 is not still known, but it is thought that it arises from the thalamus and thalamic radiation. So name at least 3 abnormalities typically found in the neonatal hyperbilirubinemia in the above test. So what do you look for if the baby has had neonatal hyperbilirubinemia and required exchange transfusion? What is the abnormality that you would look for in the Bera test? Name at least one and name the other. Okay. In the waves, what are you going to see? I have not asked about the auditory sequelae. I will ask about it later. Okay, so in the waves, what is seen that you look for the threshold, you look for the latency, and you look for the increased conduction time. So in this case, if the baby had undergone an exchange transfusion and there was auditory neuropathy, in this babies, there will be increased threshold for all the waves. There will be increased latency for wave 1 and increased conduction time between waves 1, 3, and 5. Okay, so there will be increased latency for, not decreased latency, there will be increased latency for wave 1. It will take more time to elicit that wave. Okay, so at least 2 auditory sequelae seen in patients with acute bilirubin encephalopathy. What is the typical thing that you find in these cases? High frequency sensory neural hearing loss and auditory dysynchrony. The outer hair cells are intact in this case. It's the neural pathway that is abnormal. So in these babies, they will be able to hear sound, but they will not be able to process the sound. They will have difficulty in understanding speech. So, okay, let's move on to the next question. So this shows a IVH. So which grade of IVH is this? And why? Grade 3. Very good. Grade 3. Okay. It is grade 3 because it occupies more than 50% of the ventricles and there is slight ventricular dilatation, not slight, there is ventricular dilatation also. So enumerate the components of IVH prevention bundle. Fast, a few. Yes, intraventricular extension, more than 50%. Antenatal steroids decreases the incidence of, probably decreases the incidence of IVH by 42%. Very nice. Next. Avoid milking of the cord less than 28 weeks. Okay. Avoid hemodynamic instability. Very nice. Minimal handling, rapid boluses. When you talk about avoid milking of the cord, what is it that you would try to do? TCC. Very nice. Then 30°. Okay. Very nice. Avoid hypercarbia. Okay. Avoid unnecessary handling. Use gentle ventilation, timely management of PDA, shock and sepsis, avoid painful maneuvers, thermoregulation. Very nice. Yes, everything. Also, in utero transport, prevention of prematurity, as well as in the recent Cochrane meta-analysis, it has been shown that even magnesium sulfate might decrease the incidence of IVH. Okay. So, coming to the next part of the question, mention the USG parameters which stratifies IVH into the low zone or moderate risk zone. So, the IVH can be divided into a green zone. The consequences of IVH can be divided into green zone, a yellow zone, and a red zone. So, yellow zone is the moderate risk zone. Green zone is the low. VH ratio in the ultrasound, you look for the VI index or the Levine's index. If it is more than, very nice, 97 centile. Okay, the anterior horn width more than 6 millimeter. Very nice. And anything else? Anterior horn width, yeah. TOD more than 10 millimeter. Sorry, TOD more than 25 millimeter. Okay. So you have the anterior horn width more than 6 millimeter, TOD, that is thalamo-occipital distance of more than 25 millimeter, and the Levine's index of more than 97 centile. Very nice. So coming to the 8th question, can you identify this CTG's tracing? So below is the uterine contraction, above is the heart rate of the baby, of the fetus. Why late deceleration? Because the fetal heart rate deceleration, it's not variable deceleration, it is late deceleration because it starts after the uterine contractility. Very good. And it persists, it does not return to the baseline long after the uterine contraction has subsided. What does it signify? Uteroplacental insufficiency and fetal hypoxia. Very nice. What are the components of a category 3 tracing? Okay. The components of a category 3 tracing are if there is absence of fetal heart rate variability with the presence of either recurrent late decelerations, recurrent variable decelerations, or bradycardia, or a sinusoidal pattern. Yes, very good. Moving on to the 9th question. Can you identify the fetal umbilical artery Doppler tracings here, A, B, and C? Okay, normal, absent, and reversal. Okay, okay. So the first one is not normal, it is reduced end diastolic flow. This B is the absent end diastolic flow that you rightly said, and C is the reverse end diastolic flow. Can you mention the criteria for stage 3 FGR as per Barcelona classification? Second last, fast, fast.
Dr. Nivedita, we couldn't hear you.
Yeah, I'll just repeat it again.
Yeah. Actually, we can't see your screen now.
Yeah, I am having some network issues. I'll just share it. I'll just share it right away.
Okay.
Okay, can you see it now? Should I move on to the...
It's not in slideshow. It has moved on to the 10th question, but it's, yeah, now it's good.
Okay, so were you not able to hear the criteria for stage 3 FGR?
Yeah, we couldn't hear that.
Okay. Okay, so somebody has mentioned CPR ratio 5 or more, REDF in the umbilical artery. Okay, so if the effective fetal weight is less than 10 centile, plus if there is evidence of reduced end diastolic flow in the umbilical artery, or there is the ductus venosus PI is more than 95th centile, or there is reduced flow in the ductus venosus, it is classified as stage 3 FGR. So it indicates that the delivery of this baby should be done by 30 weeks. Okay. So moving on to the last. Okay. So identify this AEG patterns. A and B. Last question. Fast. Are you able to hear me? Did I get stuck again? Okay. First suppression pattern. All right. Very nice. And what about B? So okay, A is the burst suppression pattern. It is a moderately abnormal AEG. You see that the lower limit of this in this case is less than 5 microvolt and the upper limit it crosses almost 100. So it is a moderately abnormal burst suppression pattern with extremely high voltage burst, and this is seen in cases of NKH. What about the next one, B? Status, very nice. So it is a continuous seizure activity. It is also known as the sawtooth pattern. So Dr. Kavita, we are done with the Osce also.
Yes, thanks, Dr. Nivedita. I think all questions so clinically relevant and exam oriented. Thank you so much
Thank
for
you.
for your the case discussion also and the OSCE session also. Thank you so much.
Thank you everyone.
Okay, so thank you to all the fellow students, and we'll see you next Wednesday. Bye, Sarita.
Bye, ma'am.